Direct oral anticoagulants for thromboprophylaxis in ambulatory patients with cancer. First, we have the definition. Concept. Patients with cancer commonly have a venous thromboembolism during the course of their disease. Furthermore, venous thromboembolism exposes patients with cancer to the risk of interruption of cancer treatment and may lead to otherwise unnecessary hospitalizations. Then we have video number 1.
Thrombosis is a major clinical problem in cancer patients. There's a 20-20 rule, which is that 20% of cancer patients at some point during the natural history of their illness will develop a clot. And also from a public health perspective, because the US Surgeon General has said that we need to reduce blood clots, 20% of all blood clots occur in cancer patients. So from both sides of this, of this issue, whether you're coming from the oncology side or from the hematology side, this is an important clinical problem that needs to be addressed. And it has real consequences for cancer patients. It's the second leading cause of death after cancer itself. It can lead to hospitalization. It can lead to morbidity. It can lead to a need to be on therapeutic anticoagulation for long periods of time. So for all those reasons, it's a disease with major implications for patients. Until this trial has come out, sort of the standard assessment was that we should do risk assessment of these patients, and if they are at a high risk for getting a blood clot, we should educate them about the warning signs and symptoms of DVT or PE. And that's being done, but obviously we want to do something more than that. The other things that can be done is that once patients develop a blood clot, we can give them an anticoagulant, and so that prevents recurrence of a second clot or life-threatening extension of a primary clot. But that's what we call secondary prevention. It would be great if we were able to do primary prevention, which is not have the clot happen in the first place. So there were 2 prior large trials of thromboprophylaxis that were conducted worldwide, PROTECT and SAVE-ONCO. And they both were statistically significant, but event rates in those trials were low, less than 4%. And so most guidelines and most clinicians have not adopted those findings into clinical practice because the number needed to treat to prevent one event was around 50, which is kind of high for a primary prevention approach. Also, both of those trials were with a daily self-injection, and so asking cancer patients who are already suffering from a huge burden of illness and treatment, to ask them to also take a daily self-injection for 6 months or 4 months, that's asking a lot. And so keeping all of that in mind, it generally is not standard practice to prevent, prophylax cancer patients, except when they're admitted to the hospital or if they're undergoing a major surgical procedure. So we learned from these prior clinical trials and decided to focus on a risk-adapted populations. We don't think primary prevention is for everybody, but we think it's for people who are at risk. And we define that risk using a formal rule that my colleagues and I first published in 2008, and since then has been validated multiple times. And using that score, we decided to focus on a population of patients who had a score of 2 or higher. And so that was the objective of the study, was to see if in this high-risk population, taking a daily oral anticoagulant could reduce the risk of both venous and arterial events. There were sort of 2 things about the results. One is that our goal was to have cancer patients take the drug every day for 6 months in a row. But these are cancer patients, and all kinds of things happen. Their cancer gets worse. They want to switch chemotherapy. And so on average, patients only ended up taking the drug for about 4.5 months. But the way we set the trial up, we said we would count all clots, whether they happened while they were on the drug or if they happened while they were after they were off the drug. If you count all these events, then there was still a reduction in the rivaroxaban arm, but 40% of events occurred after patients stopped taking the drug, but they still got counted against rivaroxaban. And so the reduction was not statistically significant. But we had pre-specified in on-treatment analysis, and the 2 trials, the 2 preceding trials that I mentioned, SAVE-ONCO and PROTECT, only use the on-treatment analysis. So that's more of an apples-to-apples comparison. And in that on-treatment analysis, we still found a substantial reduction of 4% absolute risk reduction, and that p-value is 0.007. Then for even the 180-day period, there was still a substantial reduction, and that's even better when you look at just the on-treatment phase. in any primary prevention approach, safety is key because first do no harm, and so we evaluated sort of well-known endpoints for safety. The primary was major bleeding, and the secondary was non-major bleeding. Both of those endpoints were quite low. For major bleeding, it was 0.99% in placebo and 1.98% in rivaroxaban, and the non-major bleeding was 1.9% and 2.7%. So fairly low rates. They're not statistically significant, but I don't want to emphasize that because the study's not, when the rates are that low, the study's not large enough to actually show statistical significance. I would rather believe that, of course, the drug would cause a slight increase in bleeding, but it appears to be manageable. Based on the prior trials, because the event rates are low, the number needed to treat is about 50 or so. In this study, even if you look at the 180-day period when a bunch of patients weren't taking the drug, it's still 35, which is an improvement. But apples-to-apples comparison would be on treatment to on treatment. And so on treatment, it's about 26. And that's actually not counting our secondary thrombotic endpoints like stroke or MI, which are also obviously clinically significant. And if you add the secondary endpoints, then it drops even further to 17. As an oncologist, we are used to primary prevention. We do it for patients, that are starting on chemotherapy. If we define them as having a high risk for having nausea and vomiting, for instance, we'll use a different
Uses in the disease. This consideration led to the concept that stratification for the risk of venous thromboembolism and the consequent use of prophylaxis only in high-risk patients could improve the clinical benefit by reducing the number needed to treat to avoid an episode of venous thromboembolism. Reducing the risk of embolism in patients receiving chemotherapy is the first goal of the use of the anticoagulants in the disease. Then we have video number 2.
Cancer can be a difficult diagnosis. With many new and overwhelming things to learn about and manage, your top priority is to get well. In addition to the other steps you may be taking to protect your health, it's important that you learn about your risk for dangerous blood clots. Cancer and some of its treatments can increase a person's risk for blood clots. Blood clots affect about 900,000 people in the United States every year, and 1 in 5 of these clots will be among people with cancer. Blood clots are a leading cause of death among people with cancer, and the risk of a blood clot is highest in the first few months after diagnosis, the time when treatment generally begins. Blood clots occur most often in the legs. A blood clot in your leg can move or break apart and travel to your lungs, which can be life-threatening. Talk with your healthcare team about your increased risk for blood clots. Make sure your healthcare team knows about your personal and family history of blood clots. Also, make sure that you recognize the signs and symptoms of blood clots. If you have been diagnosed with cancer, it's also important to understand your risk for blood clots. Some cancers pose a greater risk, including cancers involving the pancreas, stomach, brain, lungs, uterus, ovaries, and kidneys, as well as blood cancers such as lymphoma and myeloma. And the higher the stage of cancer you have, the greater the risk. Also, cancer treatments involving chemotherapy, surgery, hormonal therapy, and catheters placed in your veins can increase your risk. Lastly, other factors can increase your risk. The signs or symptoms of a blood clot in your leg or arm can include swelling of your leg or arm, pain or tenderness not caused by an injury, and skin that may be warm to the touch and red or discolored. If you experience any of these signs or symptoms, talk to your cancer doctor or healthcare provider as soon as you can.
The issue applied in Ecuador. According to the National Institute of Statistics, in the year 2012, it has been registered 1,445 cases of venous thrombosis. Nowadays, to reduce the number, professionals diagnose the causes of the clot, and then they use the proper anticoagulants as the treatment. Then we have the third video.
Venous Venous thromboembolism, or VTE, is the blood clot in the vein. It requires immediate attention. The faster you get treated, the better your odds of avoiding a dangerous complication. That's why knowing the signs is so important. VTE is actually two conditions. Deep vein thrombosis, or DVT, is a clot in a deep vein, typically in the leg. Pulmonary embolism, or PE, happens when the clot breaks free, travels to the lungs, and blocks blood flow. Signs of DVT include pain in the leg, especially the calf area, redness, swelling, and skin that feels warm to the touch. If the clot breaks free and travels to the lungs, this can cause trouble breathing. Other signs of PE are chest pain, fast heartbeat, and dizziness or fainting. VTE can affect anyone, but people who've recently had major surgery are at greater risk. So are those who don't move for lengthy periods because of long-distance travel or extended bed rest for illness or injury. Women who are pregnant or who have just had a baby are also more prone to develop VTE. Other things that may increase the risk include smoking, using oral contraceptives, taking estrogen replacement therapy, being over 40, and having a previous VTE. Effective treatment is available, so call your doctor or go to the hospital right away if you think you have VTE. That quick action could save your life. For more information,
Then we have the treatment, the pros and cons. Pros: apixaban was associated with a significantly lower incidence of venous thromboembolism than placebo in the primary intention to treat population. 2. The incidence of venous thromboembolism was lower with rivaroxaban. 3. No significance between group difference in major bleeding was observed. Cons: apixaban has a higher incidence of major bleeding episodes. In conclusion, when considered together, the two drugs showed a significant benefit of direct oral anticoagulants for the prevention of venous thromboembolism, with a low incidence of major bleeding. In conclusion, both drugs showed that thromboprophylaxis with direct oral anticoagulants in ambulatory patients with cancer was effective and safe.